Hello, and thank you very much to the organizers for the invitation and the opportunity to present. So I'm going to be talking about the immune checkpoint approaches. Dr. Jersik already talked about the monoclonals, bispecific antibodies. I think this is a little bit earlier in the development, but we've been working a lot at MD Anderson on this, and I'll be showing some of the data that we have. So I think anybody who's been here in this century probably may not need this slide, but basically the way the immune checkpoints work are routinely when you have any foreign antigen, your T cells will go and attack this foreign antigen and try to eradicate it, whether it's a virus, bacteria, or a tumor. However, tumors have learned how to escape this, and this is not specific to one tumor. This is seen across multiple tumor types. And what the tumors will do is, over time, they will result in upregulation of immune checkpoint ligands that then result in creating breaks on the T cells or deactivating the T cells. And the way of the immune checkpoint inhibitors, which was first shown by Dr. Jim Allison, who works at MD Anderson and collaborates with us, is that if you can block these breaks, you can allow these T cells to remain active much longer and do their function of fighting against the tumor cells. And I think this slide is self-explanatory. These are the approvals in the last 8 years for the different immune checkpoint antibodies. And this list has actually probably grown by 3 or 4 in the last 6 months. You've seen the new FDA approvals. But as you can see, it's not specific to a solid tumor, heme malignancy. They're approved in lung cancer, melanoma, renal, bladder, and more recently in Hodgkin's, and there are now phase 3 studies in diffuse large B-cell, follicular, as well as in myelomas that are ongoing. Also, double checkpoint inhibitor treatments now have recently been approved in melanoma, and there was positive data in bladder and renal cancer, so this could be another interesting approach. I think one of the big questions when we started this work in AML as well as in MDS, as Dr. Guillermo Garcia-Manero presented yesterday, was what are the checkpoints, what are the pathways, what are the T-cell modalities that we can use in AML and MDS. And as you can see, it's not just PD1 or CTLA-4 that are the most well-known, but there's a whole gamut of different immune checkpoints. Some are inhibitory, some are co-stimulatory. And so we wanted to see which are the ones we could target. And so we did a project with our immunotherapy platform at MD Anderson to look at a big group of AML patients. Half of these were newly AML, half were relapsed, and to try to see what is the T-cell population that is seen in AML and what are the different immune checkpoints that we could clinically leverage that are available in clinic for different tumor types that we could use going forward. I'm not going to show all the data. We presented at ASH last year, but the one that was a focus, of course, was PD1, because we did have access to PD1 inhibitors as well as CTLA-4 inhibitors. And what we saw over here is that if you look, especially in the CD8, which is probably the most important T-cell subtype to focus on, in the healthy population, which we had, you see that there is very low expression of PD1 on T cells. However, both in new AML and relapsed AML, there is increased expression. But this is not as high as you would see in melanoma, lung cancer, where single-agent immune checkpoints are shown efficacy. This is probably similar to what you would see in some of the diffuse large B-cell lymphomas, non-Hodgkin's lymphomas, mantle cell, where now there's emerging data in phase 3s that either in combination with rituximab or with IMiDs or with other modalities, these can double or triple the response rates. So based on that and based on some of the data here that has been published by numerous groups, in Europe and the United States, where they did show that the T cells are present in AML. They actually have an activated phenotype with increased CD69, increased HLA-DR, and further post-transplant there seems to be a significant increase in PD1 as well as CTLA-4 expression, and murine studies showing that with PD1 inhibition or TIM3 inhibition you could improve responses and survival. We decided to move forward. Now there were 2 important pieces of evidence that helped us kind of think how we would design studies. So one was that the single agent immune checkpoints such as nivolumab had been tried in MDS and AML as single-agent salvage and had very little to no response. However, in the post-transplant setting, CTLA-4 inhibition was shown by the group at Dana-Farber and Dr. Matthews' group to have actually quite a dramatic response. They had 5 out of 12 complete responses in people who had a full-blown relapse, so this was not MRD positive, full-blown relapse post-transplant with a median of 3 prior salvages. So based on this, we thought that we probably need to do some form of combination approach. Single agent nivolumab or PD1, PDL1 is probably not going to be sufficient.